Benzodiazepine.
Benzodiazepines in the ICU, benefits and roles. Benefits. Benzodiazepines offer several distinct advantages in the intensive care unit. They provide hemodynamic stability, making them particularly useful when preservation of blood pressure and heart rate is a priority, unlike propofol or dexmedetomidine, which can cause hypotension or bradycardia. Additionally, benzodiazepines possess potent anti-seizure properties, delivering effective seizure control that is especially valuable in patients with known seizure disorders or those at risk for withdrawal seizures. From a practical standpoint, benzodiazepines are inexpensive and widely accessible, an important consideration in resource-limited settings or when cost-effective sedation is required. Roles in ICU sedation. Despite their benefits, benzodiazepines are now considered last-line sedatives for most ICU patients due to a high potential for causing delirium, respiratory depression, and prolonged sedation that can delay extubation and increase ICU length of stay. However, several specific scenarios justify their use. Sympathomimetic intoxication. In patients overdosed on cocaine, amphetamines, or other sympathomimetics, benzodiazepines are highly effective for managing agitation, muscle rigidity, and seizures, directly countering the central nervous system excitation. Profound hypotension. When a patient is already profoundly hypotensive, e.g., from sepsis or cardiogenic shock, benzodiazepines offer sedation without further compromising blood pressure, unlike propofol or dexmedetomidine, which can worsen hypotension. Alcohol withdrawal. Benzodiazepines remain the standard of care for treating alcohol withdrawal symptoms, including agitation, tremor, and seizure risk. They may be continued orally for patients who are on chronic maintenance therapy prior to admission. PRN use with caution, using benzodiazepines, e.g., lorazepam, on an as-needed PRN basis for agitation can temporarily manage acute episodes. However, this practice risks worsening delirium and agitation over time, as repeated PRN doses can lead to paradoxical excitation, cognitive impairment, and a cycle of escalating use. Therefore, PRN benzodiazepines should be used sparingly and only when non-pharmacological and other pharmacological options have failed. Benzodiazepine dosing. Intravenous dosing. When administering intravenous benzodiazepines, it is generally best to use PRN boluses rather than a continuous infusion. Infusions tend to accumulate, leading to prolonged sedation, delayed awakening, and increased risk of delirium. A PRN bolus strategy naturally promotes using the lowest possible dose by titrating to effect in real time. Common IV regimens include midazolam, 2 to 5 milligrams intravenously every 15 to 30 minutes as needed. Lorazepam, 1 to 4 milligrams intravenously every 30 to 60 minutes as needed. These intermittent boluses allow the clinician to achieve adequate sedation while minimizing total drug exposure. Oral dosing. For patients who can take oral medications or are being transitioned from IV to mitral therapy, one randomized controlled trial validated a regimen of lorazepam, 1 to 4 milligrams orally every 6 hours for ICU sedation. Longer half-life agents for circadian support. Benzodiazepines with longer half-lives may be more useful as basal sedatives in intubated patients, as they can be given once daily, typically at bedtime, producing higher drug levels overnight. This pattern supports natural circadian rhythms and may improve sleep quality compared to continuous or frequent intermittent dosing. Commonly available options include temazepam, half-life approximately 11 hours, 15 to 60 milligrams at bedtime. Alprazolam, half-life approximately 12 hours, 0.5 to 2 milligrams at bedtime. Clonazepam, half-life approximately 34 hours, 0.5 to 2 milligrams at bedtime. These longer-acting agents are particularly useful when a sustained, gentle sedative effect is desired without the peaks and troughs associated with shorter-acting drugs. However, as with all benzodiazepines in the ICU, they should be used cautiously and reserved for specific indications due to the risk of delirium and respiratory depression. Drawbacks of benzodiazepines. Despite their benefits in specific scenarios, Benzodiazepines carry significant drawbacks that limit their routine use in intensive care unit sedation, delirium, and cognitive impairment. Benzodiazepines carry a high risk of delirium and may be the most deliriogenic sedative agent available. Their use is an independent risk factor for the development of post-traumatic stress disorder, PTSD, in critically ill patients. Additionally, benzodiazepines can cause paradoxical agitation, a phenomenon where the drug produces excitement rather than calm, potentially leading to a vicious spiral. Agitation prompts more benzodiazepine administration, which may further worsen confusion or even cause obtundation. Impact on mechanical ventilation and ICU stay. Compared to alternative sedatives such as dexmedetomidine or propofol, benzodiazepines have been shown to increase the duration of mechanical ventilation. Prolonged ventilation is associated with higher rates of ventilator-associated pneumonia, longer ICU stays, and increased healthcare costs. Dependency and withdrawal. Ongoing exposure to benzodiazepines may lead to tolerance, requiring escalating doses to achieve the same effect. Abrupt discontinuation after prolonged use can precipitate a withdrawal syndrome characterized by anxiety, agitation, seizures, and autonomic instability, a particular concern when transitioning patients from continuous infusions to enteral regimens or when attempting to wean sedation. Specific risks with different benzodiazepines. Lorazepam. Continuous infusions of lorazepam carry the risk of propylene glycol intoxication. Propylene glycol is the solvent used in parenteral lorazepam formulations. At high or prolonged doses, its accumulation can cause a metabolic acidosis, elevated osmolar gap, and acute kidney injury. This complication is dose and duration dependent, making lorazepam infusions particularly hazardous. Midazolam. Midazolam may accumulate over time in adipose tissue due to its high lipophilicity. This accumulation is exacerbated in patients with renal or hepatic dysfunction, as well as in the presence of drug-drug interactions that inhibit its cytochrome P450 metabolism, particularly CYP3A4. The result is prolonged sedation and delayed awakening, which can confound neurological assessment and prolong mechanical ventilation.